Good afternoon. I'm Kristen Askelson. I'm managing editor of the Acadiana Advocate. And today, along with KATC and Axis Behavioral Health and Recovery, we are proud to sponsor this town hall, the first in a series of 3 on the opioid crisis in Acadiana. Right now, we're in the middle of a coronavirus pandemic. About 3,000 people a day in this country are dying of COVID. So it's understandably overshadowing other health crises in our country. But in the midst of the coronavirus pandemic, there is also an epidemic of opioid abuse and overdose that is being made worse. So the panelists who are going to be joining us know all about this, but just some facts and some background about the national opioid epidemic. Going all the way back to the 1990s, pharmaceutical companies assured healthcare providers that patients would not become addicted to opioid pain relievers, and healthcare providers began to prescribe them at much greater rates. The increase in prescriptions led to abuse and predictably addiction. It soon became clear that these prescribed painkillers were actually highly addictive and could also be a gateway to illegal drugs such as heroin. By then, for many people, it was too late. In 2017, the Department of Health and Human Services declared opioid abuse a public health emergency in the United States. In 2018, 10.3 million people misused prescription opioids. That same year, more than 67,000 people died from overdosing on opioids. Of those, almost 50,000 were attributed to synthetic opioids. The remaining were attributed to heroin. So even though we're in this COVID pandemic, about 128 people die every day in this country from opioid overdose. So nationally, the overdose numbers seem to be flattening in recent years, 2018, 2019, as more treatments became more accessible, but then the pandemic happened. And in 2020, opioid overdoses have skyrocketed. Louisiana and Lafayette Parish has not been immune to this problem. In fact, Louisiana has been one of the top states in terms of opioid prescriptions per resident. So that's where we are today. And that's why we have gathered this panel of experts to discuss the crisis. First, I would like to introduce Dr. Kenneth Odenay, who is the Lafayette Parish Coroner. Next, Lafayette District Court Judge Thomas Duplanche. Lafayette City Marshal Reggie Thomas, who is also with the Lafayette Police Department for nearly 30 years. And Mark DeCluey, a nurse practitioner with Axis Behavioral Health and Recovery. Thank you to all of you for sharing your time with us today. I know you're all very busy, but it is an important topic. So to get us started, I'd like each of you to talk about the local numbers that you're seeing. Each of you come at this from a different perspective. You intersect with the opioid crisis from a different perspective. So maybe Dr. Odenay, you could start us out by talking about the numbers that you're seeing.
Well, I reviewed some numbers, and I have stuff from 2017 through 2020. And what we're seeing is a steady increase in overdoses, primarily. The drugs we're seeing now, and it's changed over time, are heroin and synthetic fentanyl. In 2017, the coroner's office reported 43 overdoses. By 2020, just this past year, where we had 84 overdoses. So you can see we almost basically doubled it in 3 years. The trend seems to be going toward heroin and fentanyl. Apparently, it's easily accessible. Most of the overdoses are polydrug. In other words, it's not just one drug. It's fentanyl with heroin or with methamphetamine. You're seeing some morphine, but the easiest stuff to get is the fentanyl and the synthetic, synthetic fentanyl and heroin. And these numbers, I believe, are skewed. I think they should be much higher. You know, one of the things we have going on is law enforcement, the fire trucks, as well as EMS. They all carry Narcan, or some type of Narcan, which is a reversible agent. So a lot of these people's lives are being saved by our frontline workers. You know, unfortunately, with this new synthetic fentanyl, it requires a lot more Narcan than normal. So some people are not making it, but a lot of lives are being saved in the front lines. So I think the numbers should be worse than they are now.
Hey, Reggie, can you talk a little bit about the numbers from a law enforcement perspective?
Yeah, in 2016, the end of 2016, I did a press conference, and it was in reference to fentanyl. And what was going on was we saw a big increase in reference to the number of the issues that we was having. And that increase started at the end of 2016. So after that, we started keeping records of what was going on. One of the issues is that Jeff Landry had a lawsuit, and we received Narcan. The police officers, the first line, received Narcan, and that really helped. If you look at the numbers, we're not keeping track of the number of lives that have been saved by the first responders. So one of the things that is going on, heroin and fentanyl is very cheap compared to what we see on the street. So it's very easy to get, and you don't know how much fentanyl is in the heroin. So what happens is we see a lot of overdoses, and we are even handling it criminally differently. You know, in the past, what we was doing was, if we have an overdose, then it's more of a medical thing, and we'll contact somebody. But now we actually do a crime scene, and we actually do investigate it further to see, could we get the dealer off the street also.
And Judge Duplanche, you know, you're seeing something a little bit different in drug court. Can you talk about that?
Sure, Kristen. So I handle a family drug court, family preservation court, where we deal with parents whose children have become involved with DCFS through the child welfare system. And so what we see in how those parents come into our program, many of them have drug-exposed newborns. Last year in Lafayette Parish, there were 84 drug-exposed newborns that were reported by the hospital. Unfortunately, not all of them get reported, because sometimes it doesn't, the marconium, they're not able to detect it till after the parent leaves the hospital. But so 84 of those drug-exposed newborns happened in Lafayette Parish. We are the second largest population of drug-exposed newborns in the state of Louisiana. We have a greater population of drug-exposed newborns here in Lafayette than they do in Orleans Parish. It's really kind of hard to believe. And when I talk to my friends about that, they don't really understand it. But 71% of the clients that we treat in our drug court program have an opioid issue. As Dr. Odnay said, it's a multi-use, but in that multi-use, there is an opioid often in that use. So that's what we're seeing a lot right now.
Now, Mark, I know that you want to take a little bit of a back seat in this. You are one of our sponsors, but you do see it. You see something different from a treatment perspective. Have you guys seen an increase in numbers there?
Oh, absolutely right. I think as we, over the past couple of years, as we've been increasing, I think, access and bringing on clinicians to, I think, see them in the office on the outpatient side of things, right, and providing access to life-saving medications, we've seen an increase tremendously, right, especially as the economic toll has taken effect over our community. People are kind of just desperate, right? And where are we going to spend what money we have? And then, yes, they need access to care. And so we, it's, our numbers have jumped up. We treat probably around 650 to 700 people in the office probably per month right now, all directly related to OUD. And we're seeing exactly what Dr. Renee had said, exactly what Reggie was saying, and that it's a lot of polysubstance, right? But primarily, the vast majority is, the concern is the opiate use disorder, right? People are, they're just wanting to feel normal, right? And they're not chasing this thing that we think they're chasing. They're just trying to avoid the withdrawals, and that's the catch, right? Because you use something that may have a little bit of fentanyl in it, you don't even know it, and next thing you know, you're one of these statistics, and it's a difficult conversation to have.
So you touched on something there. Everything changed in 2020. There's a pandemic. People are staying at home. Let's talk a little bit about, what are the factors that are making the situation worse? And y'all, we can have a conversation about this. So I don't want to call out if you want to just jump in.
I'll jump in. So what happened to us in 20 as the court system and treatment, I know Dr. O'Neill knows. So we lost our in-person contact with our clients, and it's amazing. So what we do is we have court every other week. Our clients, our parents, see our treatment providers sometimes 2 and 3 times a week, but most importantly, they attend meetings. And we in our court believe that the different meetings that the addicts attend, AANA, Celebrate Recovery, mentor programs, they're really key to the success of our people in addiction. And it's really caused a problem because now they're doing it online, and we did court online, and it's awesome that we have this ability now, but it's not quite the same. When we finally took our clients back in, they were so happy to see the judge, so happy to see the other folks. But then 2 months later, our treatment that was in person went back on Zoom. And we had a conversation just yesterday explaining to our clients that Zoom treatment should be just like Zoom in treatment in person, not walking around doing your dishes, not doing. And so it's really hard. And we think that we've really struggled with some recovery issues during this time because of the loss of access for those things.
Yeah, that seemed, across the board, right? We treat this population in an outpatient program where we see approximately 70 to 90 per week coming through, and all of a sudden to not have this access to community, because that's what it is, right? It's community. You'll have people who are coming in for the first time looking to possibly a vet to understand how to get through step 1, step 2, and step 3. And I think we forget. So it's just how I think social our community is in general, right? That we kind of feed off of each other regularly, and to not have that level of access, right? Especially during moments of stress, which is that's what's triggering a lot of some of the relapses, right? The majority of the relapses. It's how do I deal with the stress that COVID's bringing upon me, right? Being by yourself, depression, maybe losing a job, losing income, right? Losing a loved one to COVID. Just you name it. And you don't have that kick to your left where you can just ask, your partner, your partner in group. It leaves little options.
And I'm wondering, like Reggie, you talked about how cheap it is to get heroin and fentanyl, and there's been an economic downturn and people are struggling. So I'm guessing that's probably a factor in why maybe they're using some of these less expensive drugs.
I can tell you this: we have saw an uptick in neighborhoods of color, and one of the reasons is lack of jobs. Is an easy way to get income. Is cheap, and they're getting it, and they're able to sell it at a cheap rate. Opioids start with prescriptions, but when somebody cannot afford prescription, then it goes to the street, which is heroin. and then we get the fentanyl, and that's where we are getting the overdoses at. So because I believe the cost, and it's so easy to get in neighborhoods of color off the street, the uptick is something that we're seeing a lot of right now.
You know, you remind me of another point I wanted to make sure that we address, and that is, you know, the faces behind these addictions and these overdoses. You know, before we started today, I shared a story about 12 years ago, or in 2012, so about 8 years ago, my younger brother died of an opioid overdose. He was not, you know, struggling particularly. He was at a friend's house watching movies and took a few painkillers and drank a few beers, and he went to bed and he never woke up. And I think it's important to address the stigma around some of this. People think that it's mostly people of color, that it's poor people, that it's younger people. So let's talk about who it is. Dr. Onay, maybe you can start. I looked at those 84 overdoses you talked about. One thing I was surprised by is that the average age was 43.
Yeah, I was surprised by that too. What I can tell you is, you know, this problem, and I think everybody in the panel will agree, this problem does not discriminate. It's not a rich, poor, black, white, you know, Democrat, Republican. You can slice it any way you want. It's mainstream Lafayette. We've seen very wealthy families I've got calls from, and you see it in poor communities too. I think since we've lost a lot of our support system, people don't know where to go. And like you say, you lose a job, you lose a loved one, or you're just bored. Because you see a lot of youngsters in particular, and I think the judge can speak to that. They're just bored, so they're going to try something. And like Reggie said, heroin and synthetic fentanyl, it's easy access and it's cheap. So let's try it. We got nothing else to do. We don't have to go to school. School's out, and we're not working. And I think that's hurt us a lot. That's just my opinion.
Yeah. So, Kristen, in our program, I mean, I will tell you that we have we have attorneys, we have nurses. It's not just poor people. And the idea that it's just young people is not true either. One of our clients who went through our program in December of 2019 never had a sanction in the program, was graduated from the program, and some 6 months later OD'd and died on fentanyl. I mean, we thought we saved her. We did everything we could. And, you know, there's only, you know, so much. And I think Mark can tell you, you know, statistics talk about addicts seeking out treatment and help maybe 7 times before it reaches. It's one of those things that we try. We take in clients multiple times. If we think we can afford some offer help to them, we'll do it. And so it's a tough thing.
Yeah, I think if I could just take us like a step back from looking at the numbers and kind of just speak to the disorder itself. You know, something that I think we've learned, right? Society's learned, medicine has learned over the better part of the past couple of decades, is that, you know, this is not largely almost a choice, right? I'm not going to go and do this, and then all of a sudden here I am, right? The stories that I think we're hearing here are outliers to what's really typically happening, and that is, you know, somebody's get prescribed, you know, an opiate, right, because they have an injury, and for whatever reason they respond, probably genetically, different than I would, right? So they kind of get lit up a bit, and all of a sudden they need double the dose in 2 weeks, and they need double the dose in 2 weeks, and then they go through it, and then all of a sudden, you know, the doctor and nurse practitioner is going to say, I can't prescribe. This is outside of the treatment paradigm here, and so what they'll do is they'll turn to heroin, right? Because one, it'll feed it quicker, and two, it's cheaper, right? And they'll kind of push and push and push, and all of a sudden, this is what we're seeing in the clinic. And by the way, we're seeing this entire demographic that we're talking about here, right? From one end to the other. But they're using, I think, specifically not to, hey, let me find that euphoria, right? that's this. I think that's the stigma that this is. It's not, right. They're using it in order to stop withdrawals, right? They want to feel normal again. They want to be able to go to like a soccer park, right? They want to be able to go hang out with their parents, but they can't because every couple of hours they need to be thinking about, how do I find that next use, because I know I'm going to be going through horrible withdrawals. You know, one of the, I think what we, and this is, I'm getting a little bit ahead, I'll stop quickly, but we talk about time and time and time again, this is their seventh or eighth time, you know, from a treatment paradigm, we're trying to prevent overdoses and try to prevent acute events, right? Let's figure out how we can get to what is this trauma, right, that's underlying the use. One of the challenges is that people who are just coming off have a hard time diving into that trauma early because of the craving and because of the withdrawals. And I think society by and large, Lafayette Parish by and large, can do a better job in providing increased access. And I know that's for one of the other ones down the road, but initially these numbers are people who are just trying to feel normal, right? They're not people who are you know, trying to get high and they're accidentally getting fentanyl. That is a percentage. It's happening, right? I mean, we definitely is a fairly decent sized percentage, but by and large, people we're seeing in the clinic is people who are just trying to stay feeling normal. That's what's happening.
Yeah, you know, one of the things I think people get confused of is they believe that it's a criminal or somebody. In law enforcement, we get calls and we go to every neighborhood in every area. A lot of times, you know, we actually do an investigation. So you're going to run a criminal history, no criminal history, great jobs. It's just, and it's really shocking because, you know, to put a face on it. And I think we need to do that more. I think we need to put a face on it because I think a lot of people just think that it won't never happen to my family or it will never happen to me. So they don't worry about it or they don't go any farther with it. I see it going to different calls, going out there. I see different faces, and some of the faces that you see, great families, great people. You know, it's not just people of color. It's just not people in low income areas. If I think we really should do a better job of putting a face on what's going on, and I think we can get a lot more help in this epidemic. I think if I can jump on top of that, I think that's a really good point, Reggie, in that, you know, I think this population by and large want to reach out. They do, right? I think just for the past, you know, 10, 20, 30 years, right, this massive stigma and this kind of shame, right, that because we by and large, you know, as a medical community hasn't really fully appreciated what this is, right? And as do their parents. And so they're always being seen as a black sheep of the family, but when they're coming into the clinic, or they're coming into, you know, judges' chambers, right? And it's the conversation changes to one of, hey, listen, like there's no judgment being passed here. We'll take you where you are you at in this treatment, and let's figure it out, right? As opposed to pick you up out of this box and put you into this box. Like that paradigm is changing to one that is, let's meet you in this one and see what we can do. And whenever we do that, like people are gonna, part of it, this illness is relapse. It's going to happen, right? But when they do it, it's easier to pivot back whenever they know that they're not going to be forced into a box. We're going to meet you where you are. Anyway,
I think, Mark, yeah, and talking with that, and hopefully, Chris, it's okay if I jump in. But so the population that I deal with, it's hard for my friends when we talk about a stigma to understand how there are people in this world who will choose drugs over their children. I have parents who when they come into my court, I say, listen, we want to help you. We have a program. It's an awesome program. We can help you. But you need to know that if you don't take this help, if you don't try, that you're going to eventually lose your children. Your rights are going to be terminated by this court. You would be amazed how many are unable to fight the addiction. I have grandparents every week in my court. At least 5 grandparents leave my court with custody of their grandchildren. It's not what I signed up for. It's not, you know, the thing. But fortunately, there are grandparents who can come in and take that custody of their children, guardianship custody, 5 times every month. You know, I do this once a month, once a week, during the month, and it just amazes me. I tell, you know, people that, you know, at 65 years old, I don't want to really raise my grandchildren, but unfortunately, people are put into that predicament, and we try and we work with parents, but ultimately they make a decision that drugs are something that they can't do over their children.
Yeah, Judge, I would, you know, and I think I think medical theory on this now is kind of moving to one that is, you know, I don't know necessarily that these parents, right, they're making a decision, or of course they're going to use, right, but I mean, I think pathophysiologically they're just, this drug lights them up a bit more than having the newborn. That's not a matter of heart. It's a matter of, you know, amygdala sense go here and not here. And so, you know, I think part of what medicine's job, right, part of treatment's job is how can we kind of supplant that craving. And there are some treatments out there that can do that, but it's such a difficult decision because, like, realistically, you go to that parent, right, 3 years earlier when they weren't using, and like, no way in hell, it's not happening, right? It's not. And so it's,
so unfortunately, Mark, my job is to find permanency for a child in the best interest of the child.
Oh, yeah.
And ultimately, you know, but many of those parents are suffering. I think Ken said that earlier. You know, it's the trauma, the deep-rooted trauma that's there, that ultimately we as a state and we as a community owe our children and other people's children the right to access treatment. And that's where we really are struggling to find inpatient treatment, almost impossible to find it for people who don't have insurance and everything else. So we need to do, and look, our legislature is trying, we have fiscal issues, but we really need to do a better job of finding, you know, help for mental illness treatment and substance abuse treatment. It's something that needs to come to the forefront.
I know we want to address treatment and prevention, but I want to take a step back first. And, you know, we've talked about how the starting place for a lot of people is they legitimately need a painkiller and they get a prescription. So my question is, I mean, here in Lafayette Parish, are we prescribing painkillers too much? Is this a problem?
Dr. O'Neill?
It's a good question. I think it depends on who you talk to. I think it depends on what type of patients you're treating. Some people require, you know, I'm talking from a surgical standpoint, very few rounds of pain medicine. When I say rounds, I'm talking about pills. You know, a lot of it's outpatient surgery. I think when you start getting into some more complex surgery, big trauma, you're requiring more. And it really becomes, and I see it in my own practice, and I'm a plastic surgeon, it becomes a balancing act. Do they really need this extra pain medicine? Now, fortunately, I don't treat chronic pain, so I'm not writing prescriptions to people for a month at a time, but, you know, do they need this refill? And you balance it, and sometimes you try to substitute a non-narcotic when possible. But I think there are these and, you know, Reggie can probably tell you there are these pill factories out there, and they know how to find them. They know how to find them better than you and I know how to find them. And you can tell some of the drug secrets because they come in and they tell you the color of the pill and what they're allergic to and what they're not allergic to. They know more than physicians know, you know, about what you're prescribing. But I mean, there are pill mills out there, you know, especially along the I-10 corridor, and Reggie can speak to that. And it's easy transport all the way across. So I'm not sure if I answered your question or not, but it's difficult. Some stuff, yeah. I know in the last couple of years, since we've become more aware, I'm writing less prescription. I'm writing smaller prescriptions. You may come in and need a procedure, and instead of writing for 30, I'm writing for 12. And if you need a refill, I'll get you a refill in a week. But before, we used to just write for 30 and not think anything of it. But our doctors are certainly more aware, and I think all of them, I think the ones who really care are writing for fewer prescriptions for narcotics.
I think the legislature can tell me if I'm wrong. I mean, Senator Mills was really responsible in getting behind the pharmaceutical industry and making reporting much more stringent. The legislature got in there and did a lot of that stuff, which I think has helped.
It's made a lot of people aware. You know, we can check the Louisiana State Board of Medicine and Pharmacy now have a website. Well, from a doctor's office, we can go in and punch up Judge DePlanche's name and see if he's been getting prescriptions and where is he from and how many prescriptions. So we have that available to us. You know, it's hard when you're outside of your office, but in the office, the girls can pull it up. You know, if you're questioning a patient, you're not sure, you can look it up on the website and seeing if he's getting prescriptions from 4 different doctors in Acadiana, and you can say no.
Yeah,
all of us.
And that's big compared to 10 and 15 years ago when we were having a bigger prescription issue than what I think is going on now. But
and look, you would be surprised, or maybe you wouldn't be, about the patients who are asking for the pain medicine. You know, you have the stigma of what drug users look like. And sometimes it's just this sweet 50-year-old lady, and you know, you get a hunch and you pull it up on the computer, and she's been to 3 different doctors, all for narcotics, and nobody's operated on her yet.
Yeah, it's that PMP system's it's a great tool, and you know, I think oftentimes I'm kind of just upset that I have to check it so regularly, but it forces a lot of real conversations, right? I mean, I think over the past, past 7 years using the system, it's allowed, right, us, to me at least personally, to begin pivoting and asking, hey, listen, so I see here that you have a couple of scripts out here. Let's talk about why you're needing that much pain medic. What is happening there, right? And so by coming at them in a very curious way, right? It opens that door, that conversation for one that is, man, I'm just trying to feel like normal again. I just can't do it. I'm chasing, and it's been a game changer having that access to that system. It's a pain in the butt, and the legislature has required us to check it so regularly, but it's saved lives, no doubt. It's a useful system. I know, Kristen, to answer your question, the Lafayette Parish, having access to those numbers would be great. I know that by and large, Louisiana, I think you said it on the front end of the program, prescribing upwards of like 80 opioid prescriptions for every 100 people, like back in 2018, whereas the national average was like 50 per 100, right? I mean, that's kind of where we were 2 years ago. And by and large, since then, right, numbers have gone down. I mean, 2018 was the first year, I think, nationally, first year in 25 years that we saw nationally, right, a drop in overdoses. Like all of a sudden, all this effort that I think Dr. Erne was talking about, that we're hammering away at clinicians to stop prescribing as much, or to maybe tailor your strategies, it's improving. And then all of a sudden, that pickup of the second wave that we know of heroin picks up. In 2019, we have a record-setting year, right? In 2020, the synthetic opioids, which came back prior to, but then we have COVID, right? And had likely, when we're looking back on it, will probably be the worst year on record. But I don't know if it's necessarily, actually, I'm pretty confident it's not, right? The prescribing, it's still a big issue, but that's not the big issue it was maybe 7, 8 years ago. That's beginning to curb, right? But it's catching the other ones on the back end.
Well, I'm also wondering if COVID made that more difficult for physicians, especially in the early months when we were kind of shut down. And, if it wasn't an emergency, your doctor would maybe just do a telephone call with you, or the telemedicine. So it might have been more difficult to make a determination about whether somebody really needed something.
Yeah, you can look at that either way. I think you're right about that, but they shut us down where you couldn't even do elective surgery. So if that's a big portion of your practice, I mean, I was writing very few prescriptions because we couldn't operate. So, and like I said, I don't have patients, chronic patients, back pain and whatnot. So I can't speak for those guys.
And on the back end for those, I mean, so because I think, and Dr. Ernie, I think you have a much better perspective of this than I do, but I know maybe over the past decade, since Board of Medicine has kind of, and by and large, the federal government has been kind of coming down on the writing of those prescriptions, we see less access to chronic pain. But with that less access to chronic pain treatments, like has come a long way with that spike in people looking for heroin or fentanyl. And so where you weren't seeing as much during 2020, right? All of a sudden, like the substance use disorder clinic is like overwhelmed in a sense, right?
Yeah.
Well, go ahead, Reggie.
Well, I can tell you this: when the prescriptions started, when they can't get prescriptions, people find other ways, and we were seeing a lot of pills and oxy that was coming into the city. So one of the things we started was an interdiction team, getting on the interstates, and you will be surprised the large amount of smuggling that we find. Just big bags of Oxycontin, people trying to get it in. And it's not the people that you think. It won't be like people with criminal histories or anything. It's the 50-year-old grandmothers, it's the 60-year-old grandmothers that actually is bringing it in. So since the interdiction team, I really believe that some of the drug buses that we have made has been some of the largest drug buses probably in the history of Lafayette, if you look within the last about 2 years, especially with Oxycontin and different types of painkillers that they're bringing in. So that was one of the things that the police department has done and continue to do. Sheriff's department also is watching what's coming into the city. And I think we're doing a good job of stopping that and making really good arrests of people that's smuggling those type of items into Lafayette City.
Hey, Reggie, where do we know where it's coming from? Are they able to track that?
Yeah, that's a part of the investigation. A lot of times, especially on the interstate, they're just using I-10. So a lot of time it's not coming to Lafayette. It might be going to Texas, coming out of New Orleans, might be going to New Orleans, so it's different areas that it's coming from, but a lot from the large cities like the Houstons and the Dallas and Florida is a big area. And it's just trafficking a lot of times. And, when we are doing interdiction, doing traffic stops, the loads that we're getting, it really amazed me because we just started doing that within the last 2 years. And it started because when we started talking to people who has a large amount of Oxycontin, they're telling us that's how they're getting it in. Also, Greyhound buses is another area where they're really getting it in at. So we're on top of that and we're working that. And I think everybody working together with the prescriptions, with the interdiction that we're doing, I think we can lower the usage or the overdose rate.
Yeah.
Reggie, whenever you're talking about the interdiction, I hear you're mentioning like the commonly prescribed opioids. Are y'all also including in that mix or in that data that you're pulling like the heroin or the synthetic opiates like fentanyl as well? Is that kind of in that? I mean, those are getting trafficked. Those are getting trafficked as well. Are those in your numbers? Yeah.
Yes, those in the numbers. We go from opioid to heroin to fentanyl. Those three are all running the same way.
Yeah.
Well, let's talk about that. So, prescription painkillers are one thing, but then as you all have said, when people become addicted to them and they can't get them anymore, then we're talking heroin and fentanyl. And fentanyl is scary. Like, a few years ago, this was something that didn't seem like, was in every town. This was something that you heard about with celebrities or, big stories. And now it seems like it's everywhere, and it doesn't take very much to overdose. So can you guys, what is going on with the fentanyl? Why is it so easy to access? Where's it coming from? What do we do about it?
I did and Reggie might have been part of that. I did a warrant. I remember the lady who, and I'm pretty sure I have this right, Reggie, the lady who was a student up in Shreveport or whatever and died at Girard Park. And I did the warrant and I didn't know what it was. So I had to call the officer and say, what is this thing what is this you're talking about? And that was, I don't know, not that long, 3 years maybe.
Yeah, it might have been 4 or 5, but I remember the case you're talking about.
And I had never heard of it before. And now I had to tell you, in my search warrants that I'm doing, in some of them, I mean, fentanyl is, and it is, I know Ken can probably talk about that, because I have had literally high school, college friends whose close people have died as a result of fentanyl. I mean,
it's a drug. If you're in the operating room, it's easy access. It's used every day in the operating room. It's a very strong painkiller. It doesn't have as much side effects as some of the more traditional morphine and Demerol as far as nausea and vomiting. So it's a great drug. What's happened though is people, and I know what Tommy's talking about because I've heard of, you see it in anesthesia students and people with access to it get depressed and shoot a little bit up, and it doesn't take much. And, they suffer respiratory depression. But they're making it out of China now. It's the synthetic fentanyl, which is stronger than what we normally use every day. I don't know how it gets here, but the side effects are much worse. It's much more powerful. And as you know, they don't know what they're getting. They just know they're getting something that's going to take care of that withdrawal, and they die. Now, I was talking to one of the ER docs about the normal amount of Narcan you give to reverse regular fentanyl or morphine doesn't work. You need a double or triple the dose, to save them. So that's what I tell you. A lot of it's made in China, and you don't know what you're getting. It's not like going to the pharmacy and getting it.
And I would tell you this, many times when we go to overdose, fentanyl is so strong that the syringe is not even removed from the arm. It is when we get there, the syringe is still in the arm. So that shows you that as soon as you shooting the fentanyl in, then that's it, immediate. So that's how strong fentanyl is, and that's what we're dealing with.
Yeah. I think it was brought up a couple of times, Dr. a minute ago, and Reggie did as well. I think something that we've done a really good job, I think, over the past couple of years, but we can do a much better job, and that's we in Lafayette Parish, but I think the country by and large is, I think, make sure Narcan is more readily available, like almost as readily available as CPRs are, in the mall, right? It should be, everywhere. That's how many overdoses we're having, right? I remember last year, right before COVID came around, it was probably like once a week I'd pick up, it can be an email, but you read about, Columbus's overdose epidemic, right? And it was every week was a new city talking about overdose epidemics. And then we hear Dr. Ernie say we had 80 over the past year here in Lafayette Parish. We should be doing a better job, I think, educating, our community about not only about the dangers, right, but like what to do whenever you see it, right? And we should be having Narcan available. As readily available as CPRs around. Defibrillators around the city.
So Judge Edwards had a grant in his drug court, and everybody who was a member of the adult drug court left with the Narcan, the so that they could administer it, not necessarily for them, but because of the community they're in, so that they would have it available. And he was,
Judge, whenever you saw that, you see, so we did the same thing. We had samples that we would give away, and it was kind of coming from a different source, but a grant nonetheless. And people's face kind of light up when they see that they can have it in their home. And so we say, listen, they say, well, this isn't for you. This is for you to tell your partner, tell your kids, tell your mom who's living with you where the Narcan is, right? But people light up because of how prevalent, how often people are overdosing, you know.
But talking about the stigma, I have friends who say, well, why would you do that? You're just encouraging people to use drugs. And I'm like, no, I'm not. I'm encouraging drug users to help others not die. But it's a discussion. I mean, and it's hard.
It's just there's this catch-all phrase, right, that we kind of put all of this under, and it's like a harm reduction, right? It's like what can we do to make sure that the least amount of harm is done, right? And it's one of these, right? And so no, it's people are going to catch. They're going to catch, and they come 6, 5, 7 times. They may be there, right? This is part of this journey, right? And no, you do what we can for our community, right? We try to be there for them because maybe the next time. They actually, instead of going to one of the Zoom meetings, they get to go to a live meeting, and they meet, the guy who's got 30 years under his belt, and all of a sudden they realize there's somebody who speaks to the trauma that they've been experiencing for the past decade, and it's we have another positive member in our community. It's I think back on a couple of stories like the past year, success stories, but we need to be able to give them that option, and like being able to just save a life in that moment is like it's necessary.
So one of the things that I keep in my office and require, and I don't have an interest or anything in it, is it's a book called Beautiful Boy by David Self, who's goes through the battle with his son and addiction, and it's just amazing. And another one, Casey Foundation recommends, is Dreamland. 2 great books for particularly families dealing with addiction. So
just getting back on the Narcan, one of the things is it's so easy. Is we use the nasal, and it is just a spray. And I think we should get it out a lot more. It's many times that I would go on calls and we have an overdose, and I think to myself as a young person, if a parent who was there earlier, if they just had some Narcan, if they had anything, we could save so many lives, and officers who actually go to the scene, they pretty much could recognize immediately that they need to use the Narcan, and have saved many of my officers have saved lives in reference to it. So I encourage that we go out and we try to get more Narcan in the city. And one of the things is it's so easy to use. We use the nasal. They have different types, but we find that the nasal is really easy to use, and it does save lives.
So I know I promised to get you guys in and out of here in under an hour, and I don't want us to finish without talking more about prevention. So in addition to the Narcan, I'd like to finish with each of you maybe weighing in from your vantage point on what we can or should as a community be doing toward prevention of addiction, of overdose. Just jump in.
I'll jump in here. Right? We do it regularly, right? We do it regularly because this use disorder is there is genetic predisposition, right? All of a sudden we see families where we're treating a couple of brothers, or a mom, a brother, and the brother's kids. So it's they're always asking, hey, so how do I need to prevent here? How do we do this, right? And so the first thing is we say, listen, you need to start getting rid of your medication whenever you're done using it, right? And so it probably guilty at some levels, my house as well, but we tend to not get rid of our medication that we don't use. We tend to take it, store it in top cabinets, right? We tend to wait until that one time where we maybe broke a tooth, right? Oh, here's this medication to help me with, with my surgery that Dr. Odene provided on, whatever the case may be. But kids are curious, right? And whenever mom and dad are away, right, so parents are away, they may be going to seek out there, right? And so getting rid of, I think, extra medications that we don't need, right? And then going back to your physician, your practitioner, your PA, whoever it is, whenever you need treatment, that's number one that pops up with us, is just get rid.
So one of the conversations that we're having in the child welfare arena and others is, how do you deal with trauma? And if you could deal with trauma, which is the base for so many of the parents who come into my court. And so we've started a trauma-focused, trauma-informed. Heather Blanchard, Mark was talking about before, is on our team. And we're trying to get out into the school system to let teachers know that kids who are acting up in a class aren't necessarily doing it because oppositional, defiant nature. It's because there's a trauma in their life that triggers these things. And those same traumas are what triggers addiction in so many of the people that we see. So you asked me what we can do for prevention is seek a way to help people deal with the trauma that's in their lives. It's one of the main focuses our treatment provider does in our program. And that is whether it's because of past sexual abuse, physical abuse, alcoholism in their family. There's an ACEs program that we do with many of the people that come in, and that are the 10 components that get you, that you ask, and that you're much more likely to be either in addiction or criminal activities because of the things that have happened. It's an easy thing to ask and to do. And so I just would implore, people, physicians who are seeing them, to explore whether there's a trauma in there that's doing that.
Prevention for us in law enforcement is doing better investigations. We have to investigate and we have to charge people appropriately. And the people that I'm talking about charging is the drug dealers. If it's not worth it financially, or if we inform, educate people, and people actually see that we will prosecute if you're caught dealing these drugs. I can tell you that when we investigate and when fentanyl is used and you're the dealer or whatever, you can be charged with a second-degree murder charge, from the overdose. And, once the investigation is done properly, once we get toxicology and we get everything back, I think we have to educate the public more and say, look, it's a serious offense. You're killing people. So we have to investigate better, and I think we're doing a better job at it. But we need, we used to, when we have an overdose, just have somebody from the narcotics come out and confirm it. Now we actually do a crime scene. We actually do search warrants to look at what phone numbers has been being called, and so we are trying to charge people, and we're trying to deter people from actually becoming drug dealers. It's not about the money. We're talking about saving lives here, and I think we're going to continue to do a good job in investigating, or a better job in investigating. And I think if we bring people to the court system and they actually see people actually getting punished for these type of crimes, I think it'll slow up. I really do.
Dr. Odene, a final word from you on prevention?
Yeah, I'm looking at it from a different viewpoint than the other panelists, and I agree with everything that's been said. And I'm looking at it from the eyes of a parent. My kids are older now. I went through it with a bunch of siblings. I think you've got to educate children, and that's bringing people into school to talk to them. It can be previous, people who've had previous problems with addiction. But I need, law enforcement, I think, is key. Bringing them in to talk to the kids when they're young. a lot of times, and I think Judge and Reggie can tell you, by the time you get to them when they're 16, 17 years old, you've missed the boat. I think if you can get into them when they're young, you can have an effect. And, parents, I went through it with my parents and did it with my children. I think that would help a lot.
Gentlemen, go ahead, Mark.
If I can just piggyback, Dr. One said something a while back that's just really, it's key, right? And I think, Dr. One, when you were talking about your surgeries and you're prescribing like less than maybe you did like 5 years, whatever ago, right? In shorter increments, right? And maybe, I think whenever we see people in the clinic, I think encouraging them to maybe not necessarily take, whenever their kid may have a broken bone, not necessarily because of the genetic predisposition, or encouraging them that, listen, this is actually something you could pass on, the likelihood of a risk is developing. And so not necessarily going to an opiate for the first time you break something, but the smaller measures. That's right. So thanks.
All good advice. I want to say I appreciate all of you. You are all busy. You are all out there doing the hard work and the good work, in part helping us combat this crisis in Acadiana and nationwide. I appreciate your time so much. The Acadiana Advocate, we think this is such an important issue to our community, even in the middle of a pandemic. So we have 2 more town halls on this topic to discuss different aspects of it. One is going to be February 9th. The other one is going to be March 9th. I hope you will all join us again for that. Like I said, I wanted to get you in and out in under an hour, and we are at about 58 minutes. So I'm feeling pretty good. Once again, thank you to Axis Behavioral Health and KATC, who are our partners on this important project. Gentlemen, enjoy the rest of your day. And for those of you in the audience, thanks again for joining us.
Thank you.